I will go ahead and get started. Awesome. Welcome everybody to our Women's Health Group Part 2, focusing on self-love and a healthy heart. So we're so excited to be into week 2. Our first week, we kicked it off with Kim Larson, talking about self-love and affirmations and finding those kind words to talk to ourselves. We had a positive word last week. We had over 20 people participate in those words. And we want to congratulate our winner, Jennifer Newhouse, who's on today, and happy birthday this week, who was the winner of that. So her word was believe. So believe in yourself, and you can do anything. Week 2, we already have words such as consistent, determined, grateful, committed, kindness, and I am the light. So our self-care bingo, congratulations to 23 people who turned in their bingo cards, and Rebecca Frith was our big winner this week. So congratulations to Rebecca to earn some bath salts, body bombs, and bath wash. So week 1, we had 17 women log in their workouts and 14 log in their Shakeology. So remember that you can win that $20 gift card at the end if you continue with the consistency of 3 times a week. And without any further ado, this was my favorite time, is to introduce our speakers, and very excited next week. Put on your calendar, because Heather Glenn, our functional nutrition therapy practitioner, is going to be talking about the importance of eating for your heart. Eat like you love yourself. Okay. So, but without further ado, I am super excited to introduce Dr. Nita Harris. I've known Nita for a while, but it seems like it's always kind of through Facebook or text or seen her at things, but we're really excited to have her here. She's at Penrose Cardiology right now, but she's been trying to retire since 2019, but everybody keeps wanting her back. She's been married to her husband, Brad, for 25 years. Congratulations to you. That's a big milestone. I'm sure they're going to do some traveling to celebrate that one. Her son, Aiden, is working on his master's in mechanical engineering. Super bright, graduating in a month from Boulder. So Heather, I know you went to Boulder, so you'd be proud of that one. She loves to travel. She loves to travel, and she loves to travel. Is that correct? She loves biking, hiking, skiing, snowshoeing, and also cooking. And she said she'd be willing to share her healthy roasted salmon recipe with us later. She moved to Colorado Springs in April of 2003, started with Pikes Peak Cardiology, but grew up in Louisiana, which you'll quickly see with her beautiful accent, and went to LSU in Shreveport. Then went on to Knoxville, Tennessee for training in nuclear cardiology. And hopefully she'll explain to us exactly what that means. To me, that sounds really super duper smart, nuclear piece of it. Then back to LSU Medical Center to teach the medical students, residents, and fellows, then off to Little Rock in 1995 to start her own private practice. So she's been in cardiology for 30 years. She spearheaded the first Go Red for Women with the American Heart Association in 2003. And I've been lucky enough to witness what an amazing program that is. And she co-chaired it for 15 years. That's a lot of work and time and effort and volunteering. So thank you, Dr. Harris. Her favorite type of exercise is walking, hiking, biking. She loves her new e-bike that she's using, and loves roasted veggies, roasted salmon. She keeps on saying she's semi-retired, but she keeps sending me the list of all these places that want her to work for them. So she's at Colorado Springs Cardiac Rehab at Penrose. She's at the Outreach Cardiology Clinic in Canyon City. So in the meantime, she loves to travel when she's off work. So without any further ado, please welcome with a round of applause to Dr. Nita Harris.
Thank you, Christine. So I'm going to first address what nuclear cardiology is, just to say that. So we do stress tests to evaluate patients for the presence or absence of blockages in the arteries. And one of the stress tests that we use is a nuclear stress test, and that can be done either walking on a treadmill or using a medication for our patients who cannot walk for various reasons or can't walk far enough to stress their hearts. And so we use a small amount of radioactive materials before and after the stress test to make images of the heart. And that helps us figure out whether or not there's a problem with circulation in the heart itself. And that requires additional training to what you get in general cardiology. So, and it's also a separate, there's a board certification process that is separate from being board certified in cardiology. And when I was working full-time, I was board certified in both. Now I'm just board certified in general cardiology. So at any rate, I'm happy to be here today and talk to everybody about the really important topic of heart disease in women. There are excuse me, lost my train of thought there for a second. It happens when you get over 60. Anyway, over 60 million women, or 40% of women in the United States, are living with some form of heart disease. And until the early or mid 2000s, if you ask women in the general population what they thought they would die from, the majority of women would say cancer, with an emphasis on breast cancer. And in fact, the majority of deaths in the United States, women at least, is from heart disease. 1 in every 5 deaths in women is from heart disease. And even now, only about half of US women, or 56%, recognize that heart disease is their #1 killer. So it's not so important to recognize something bad like this could kill you, but to recognize that that is a fact and say, what can I do to alleviate my risk or decrease the risk of dying from heart disease? So that's what the focus of today's talk is not to be a bummer and say, oh my God, you're more likely to die from this than anything else, but to say, here's what you can do to decrease that risk and increase your lifespan. So the most common types of heart disease in women, #1 is coronary artery disease, which is what we mean when we as cardiologists discuss heart attacks, angina or angina, as some people call it, stents, bypass grafting, and so forth. Those are all related to the presence of coronary artery disease, which is blockages in the arteries that supply blood to the heart itself, which are the coronary arteries, therefore coronary artery disease. Because the heart itself is a muscle and requires constant blood flow with oxygen and nutrients, just like every cell in our body does. And so when you limit the blood flow to the heart muscle itself from a blockage in an artery, that's when problems develop, and heart attacks, angina, and so forth can occur. Is the leading cause of death in women. And after menopause, so let me back up. Prior to menopause, women have a lower risk of developing heart disease or dying from heart disease than men, particularly coronary artery disease, I should specify. After we go through menopause, women's risk of dying from a heart attack increases to equal that of men and then eventually exceed that of men, so that more of us are dying from heart attacks than men after we go through menopause and get into our older years. Unfortunately, as we age, as we women age, other things can happen, and there are things that are related to our body habitus that are not present so much in men, in that in older women, particularly 70s and 80s, the arteries become more friable so that they're not as structurally sound. And so we're limited in some of the interventions that we can do on older women because of that. And so it reinforces the need to really pay attention to what you can do to prevent that issue from ever coming up. The other problem with women in heart disease is that we just don't have time to be sick. And I've heard this so many times in my practices. Yeah, well, I started having chest pain, or I started noticing I was more short of breath than is normal for me with my normal activities about a year ago. But, you know, my son was getting married, my daughter was graduating from college, my husband was sick. All these things that we women in general are caretakers of everyone else, and we're not such great caretakers of ourselves. And so I've heard that too many times, like, why didn't you come to the emergency room, or why didn't you make an appointment? I was taking care of everybody else. And so I guess the primary point from this should be, you first have to take care of yourself so that you can take care of everyone else. And I know that a large focus of this group, Christine, is self-care and taking care of yourself. And I don't think it applies any more than taking care of your heart. So I'm gonna climb down off my soapbox now and get back to my talk. So we're going to talk more about the risk factors in developing coronary artery disease. I want to stop and make a point, though, that most strokes are caused from atherosclerosis as well. Atherosclerosis is the buildup of cholesterol and fat plaques in the arteries. My specialty focuses on those plaques in the heart itself, in the coronary arteries themselves, but those plaques can develop in any artery in your body. These arteries that lead to your brain are the carotid arteries. They can develop atherosclerotic plaquing, just like coronaries do. That can extend into your brain, into all of the arteries that supply blood to the brain itself, and that can cause a stroke. And so in just a moment, when I get to the risk factors that cause atherosclerosis and therefore coronary artery disease, you can extend that to other arteries and to reducing your risk of stroke as well. One of the other more common types of heart disease in women is arrhythmia, or abnormal rhythms, the most common of those being atrial fibrillation. And you can't turn on the TV now without seeing an ad for Xarelto or Eliquis in relationship to atrial fibrillation, and there is a reason for that. Atrial fibrillation is the most common cause of stroke in the United States as well. And it's because when your heart is not in a normal rhythm and is in the irregular rhythm called atrial fibrillation, the top chambers of the heart, the atria, don't squeeze and pump the way they do like in a normal rhythm. These pump first and the ventricles pump next, and it's all done in microseconds, so you don't perceive it as two different things, but it does occur that way. In atrial fibrillation, those top two chambers don't squeeze as much as they fibrillate, and if you opened someone's chest and looked at their heart in atrial fibrillation, it looks like a bag of worms because the electrical stimuli are occurring from the entire atrium, and there's hundreds, thousands of sites of electrical tissue within the atria, and they're all trying to beat at once, but it's not a concerted effort, so you don't get that nice squeeze. And when that happens, when there's not a concerted movement, clots can form. And that's what the blood thinners, Eliquis and Xarelto, are for, is to prevent that clot formation. So important to take note of that and don't ignore feelings of your heart racing, beating irregularly. I know that there are smart watches now that can detect atrial fibrillation. They're not perfect, but they've been around long enough and they've improved their technology enough that we in the cardiology community and in the American College of Cardiology are starting to recognize that those can be a beneficial tool. Unfortunately, the quality of the EKG that you get from those or from the apps where you can do like mobile EKG, they're limited in some ways because of artifact, but they can be helpful. So if your smartwatch or your mobile EKG app tells you that you might have an abnormal rhythm, that is a reason to contact your primary care physician and begin a workup like, do I have atrial fibrillation? Because it's an important way to prevent a stroke. The third most common type of heart disease in women is heart failure, and that is a completely different, very broad topic that I won't cover anymore today, except to say that heart attacks or coronary artery disease can damage heart muscle to the point that it dies, and that can lead to heart failure itself because you don't have enough heart muscle squeezing to take care of what needs to happen. But at any rate, a lot has been made and a lot has been discussed about the symptoms of heart disease in women and how it can be different than men. And that is true. But also, I think it's important to mention that the most common symptom of coronary artery disease in women is the same for men and women, and that's chest pain. Typical chest pain or angina occurs in the mid-sternal region, the middle of your chest, or to the left, but it can be all across the chest as well. And it's typically described as a heaviness or pressure sensation, and it can radiate to different places. Everybody knows about the one going down your arm, but it can also radiate into your neck and through to your back, and sometimes can occur more in the epigastric or upper abdominal region. Some people sense it there. I had a patient who spoke at one of the Go Red Women events in the past, who her angina was manifest when she walked her dogs. She thought she was having a sore throat, and it only occurred when she was exerting herself, and that was her angina. And she was smart enough to say, this isn't right. It only occurs when I exert myself, and it goes away when I rest, which is another classic sign of heart disease, whether you're feeling shortness of breath with exertion or some sort of discomfort. It's important to pay attention to that. And she did, in fact, have a blockage and needed a couple of stents. And she was a very healthy lady. So I think I've covered most of the risk factors, but the take home point from risk factors in women, on symptoms in women is just to not ignore something that's new for you. And especially one that occurs when you're exerting yourself or when you're emotionally upset and then goes away. That's something to call attention to your primary care doctor. Most primary care providers now are attuned to this, but there are still some who buy into the whole, oh, you're a woman, this couldn't possibly be your heart, when that's not the case. If you go see your primary care doctor and you feel like you are being, pardon the term, blown off, go see another primary care doctor, because your needs, your concerns should be addressed as seriously as anyone else's. So again, step back off that soapbox and get back to the risk factors for coronary artery disease or cardiovascular disease, which encompasses heart disease and stroke. Hypertension is the major risk factor for heart disease. Hypertension, high blood pressure, as it's called. Over 56 million women in the United States have high blood pressure. And that means their blood pressure is over 130/80. This includes almost 1 in 5 women of reproductive age. So this is not a problem that just occurs in menopause or postmenopausal. It is often underdiagnosed in women, and fewer than 1 in 4 women who have diagnosed hypertension actually have it under control. Black women are nearly 60% more likely to have high blood pressure than Caucasians. Pregnant women with hypertension have twice the risk of developing heart disease later in life compared to pregnant women without hypertension. And in the United States, high blood pressure develops in 1 out of 8 pregnancies. So that's a huge number. And hypertension is a risk factor for developing cardiovascular disease, but it's also a risk factor for developing heart failure, which I'm not covering so much today. But hypertension that is not controlled can also lead to kidney failure and is a leading cause of stroke as well. On really high blood pressure can lead to a hemorrhagic stroke, which is a stroke that is associated with bleeding into the brain. And anyway, so the other, so it's important to first identify whether or not you might have high blood pressure. And then second of all, to really focus on getting it under really good control. And I think that it's really important to take possession of that and follow it yourself with blood pressure cuffs at home and so forth, so that you have data when you go see your primary care doctor. But so at any rate, the other risk factors for cardiovascular disease or coronary artery disease are having a high cholesterol, particularly a high low density lipoprotein that's called LDL. Smoking is a risk factor, diabetes, excessive weight, an unhealthy diet, physical inactivity, drinking too much alcohol, and something that's been added recently, when I say recently, I mean in the last 10 years, is stress and depression. That did not used to be on our list of risk factors, although we knew that it contributed to it. We now recognize it as even more of a risk factor. We women also face specific factors related to our reproductive health and pregnancy. And so your risk of developing coronary artery disease or heart disease in general is increased if you had your first period early, like before the age of 11, if you had early menopause before the age of 40, if you have polycystic ovary syndrome, if you had gestational diabetes, meaning diabetes while you were pregnant, if you had a preterm delivery, if you had high blood pressure during pregnancy, I already mentioned that, and if you delivered a low birth weight or a really high birth weight infant, those are all contributory to the increased risk of heart disease. So that's all the bad news. So how do we change that? And how can we reduce our risk of heart disease as women? Well, so first of all, and this is beating that same dead horse, know your blood pressure. And talk to your doctor about your blood pressure. Talk to your doctor about whether or not you should be tested for diabetes. There's a very simple test now that can be done called a hemoglobin A1C, and that value is calculated, or the hemoglobin A1C is based on what your blood sugar has been for the past several months. So it's a very good gauge of not a blood sugar at one specific instance, which all of us, when we eat, our blood sugars go up because you just ate, you're absorbing what you eat, and then your body's going to turn that into energy and new cells of all sorts. But at any rate, that's just one point in time, whereas the hemoglobin A1C is over several months' time. There are ranges for what's pre-diabetes and normal. I personally, about a year and a half ago, saw my primary care, Dr. Wendy Day, and was identified as being pre-diabetic. And I already have, because of my family history, high blood pressure, high cholesterol, and my sibling has diabetes. So that's like a trigger to check me. And I was in the pre-diabetes range, and under her guidance, lost 30 pounds and got more active, and my hemoglobin A1C came back to normal. So that's just a illustration of what you can do for yourself, right? Then if you smoke, quit smoking or don't start smoking. And vaping is not a healthy alternative. So I'll stop with that. So I was also involved with the campaign about vaping several years ago to try to get it on the ballot. But anyway, or no, when we were trying to get the tobacco tax raised to a uniform level across the state of Colorado. Anyway, talk to your doctor about checking your cholesterol and triglycerides. Get at least 150 minutes of physical activity each week. And I know that one of y'all will be talking about that in much more detail, so I'll leave that alone. But the American College of Cardiology and the American Heart Association recommend that you get at least 150 minutes of moderate physical activity each week and at least 2 days of weight training with low weights. The other way you can reduce your risk of heart disease is to make healthy food choices. I'm sitting here staring at your t-shirt, Christine, and it makes me, that's an easy one to remember. Being overweight or having obesity raises your risk of heart disease, and making healthy food choices can, of course, help you lose weight. Limit your alcohol to 1 drink a day. And it's not fair, but it's 2 drinks a day for men. And manage your stress levels by finding healthy ways to cope with stress. I see a lot of patients who have problems directly related to stress and anxiety, and have sat in an exam room many a time and illustrated diaphragmatic breathing techniques, which work really well. So I wanted to touch a little bit more on diabetes and pre-diabetes as they relate to heart disease, because that is a really huge risk factor for coronary artery disease. In my line of work in cardiology, I consider every diabetic I see to have coronary artery disease in some form, and it may be subclinical. They may just have minor blockages, but they're there. And it's my job to fix it, is the way I look at it. The other thing is there are different guidelines for managing risk factors for diabetics than there are for non-diabetics. And specifically what I mean is a normal LDL or bad cholesterol for a non-diabetic patient is around 100 if they don't have pre-existing heart disease. For a diabetic without pre-existing heart disease, the goal for their cholesterol is the same as the goal for a person who has had a heart attack, a stroke, bypass, or a stent, and that is 70 or less. And so that's important to know. So if you're diabetic and your doctor says your cholesterol or your LDL, let me back up. In all diabetics, regardless of their LDL, I think they should be on a statin to lower their cholesterol, period. And it's because their risk for heart disease is so high. So anyway. What are the risks of diabetes and prediabetes? It's, of course, if you have prediabetes, then you are at risk of developing diabetes if you don't address what's causing it. If you're overweight, if you're over the age of 45, if you have a parent or a sibling who had diabetes, if you're physically active less than 3 times a week, that increases your risk of diabetes. If you had diabetes while you were pregnant or gave birth to a child over 9 pounds, and if you're African American, Hispanic or Latino, an American Indian or an Alaskan Native, your risk of diabetes is higher. I already kind of touched on, I'm gonna move forward to cholesterol. I already kind of touched on that, but I want to mention that dietary cholesterol is found in all animal products. We no longer believe that the cholesterol content of a food is as important to control of your cholesterol as fat is. And there are, of course, different types of fat. But the fat in your food contributes more to your cholesterol than the cholesterol in your food. So you might, for an example, shrimp is high in cholesterol, but has almost no fat. And it's okay to eat shrimp. Eggs have cholesterol, but have, like, I just saw an article yesterday, and this has changed so much in the 30 years that I've been in cardiology. Eggs and coffee have been all over the place as far as whether or not you should have any at all, a limited amount, have whatever you want, etc. So the American Heart Association and the American College of Cardiology now say you can have 2 eggs a day, and we recognize that as a healthy protein. And coffee, it changes all the time, but at any rate, optimal levels for your cholesterol are a total cholesterol of less than 150. And this is in the general population, not someone with heart disease, not someone who's diabetic, not someone who's at high risk of developing heart disease. That's what these numbers apply to. And LDL needs to be less than 100. LDL is the low density lipoprotein or bad cholesterol. HDL is a high density lipoprotein. It's good cholesterol, and it needs to be above 50. And then triglycerides, which are free fats in your bloodstream, need to be less than 150. Sometimes, this is just an aside, I suspect someone's diabetic without knowing they're diabetic by looking at their triglycerides. If they're markedly elevated, that's a big clue that they're diabetic. So I'm going to close with that and take any questions.
Wonderful. Thank you so much for all this good detailed information. I think it makes us all recognize that with the risk factors of being a woman and in that menopause, that it's even more important to take care of ourselves. And I love your example of how you met with Dr. Day and worked on your own to show that even though you're a cardiologist, you're susceptible as a lot of family history that you deal with. And to be able to say that you've kind of beat that pre-diabetes is amazing. And Dr. Day will be speaking in 2 weeks. So it's nice that you guys are connected as well. So yeah, at this time, I'd like to open it up to everybody to ask questions. It's amazing to see that we have people now online from Iowa, Washington, Texas, Utah, Colorado, and California. So Dr. Harris, you're across the United States here, which is pretty awesome. So I'll open that up for some questions now.
I didn't want to be the first one to jump in, but I will. Dr. Harris, what would you say in your experience has been the most impactful thing that someone can do if you had to pick one thing to take them out of uh, the high risk area? Like if they either have diabetes or they're have some type of cardiovascular issue.
Get off the couch.
Okay.
That is by far, and it impacts like exercise impact. And I'm not saying this because this is a women's group that's focusing on exercise. I say this every single time I see a patient. What are you doing to move your body? Because exercise decreases the risk of many other things other than heart disease. We already touched on. So exercise can help control blood pressure. Exercise helps lower your blood sugar because you need extra carbohydrate or energy to fuel any kind of workout or walk or just moving. Exercise lowers stress, which lowers your blood pressure. Exercise helps you keep your weight under control. Exercise helps you continue to move as you get older so that those joints stay a little bit more lubricated. Exercise helps reduce your risk of breast cancer. I'm a breast cancer survivor, and so that's something near and dear to my heart. So I like being able to incorporate it into a talk about heart disease too. But exercise, exercise, exercise.
Well, that's great to hear, because that is one of the big things that we're focusing on in the group. And another like kind of side question to that, and I think I know the answer, but want to confirm, because you talked about how heart failure, or like how as you get into 70s and 80s, the blood vessels just get, weaker and thinner. And I'm thinking in my head, okay, well, how do you make those stronger? And would that be exercise? Like, how do you strengthen, like preventatively now?
Unfortunately, not so much. I mean, like you can improve your overall, or you can decrease your overall frailty by exercising and continuing to exercise. The blood vessels and the status of the blood vessels depends more on internal factors such as blood pressure, diabetes, cholesterol. So taking care of those things, I guess it could be extended to that if you consider the fact that exercise helps reduce the risk of any of those risk factors, and also helps to manage any of those risk factors. Then yeah, I guess you could just generalize it to that.
Yeah, so it sounds like
But
if you're working on, go ahead.
I think the more important thing is that like exercise helps you, it helps you keep your balance. It helps you avoid some of the, and something I didn't touch on with the older, like much older, like octogenarians, some about my battery's dying. Just on my iPad, not me. But anyway, so I lost my train of thought.
Did you say?
Oh, I know what it is that as you get older, we tend to have more comorbidities, as we call them, or associated illnesses. And most of those are the ones that I just touched on. And so continuing to exercise as you age helps improve your overall risk balloon, or I don't know the word I'm looking for. Help me out here. Your risk status in general.
Okay, great. Thank you.
I had a question, it's more of a, how do you give hope to, there's so many people that have so many of those high blood pressure, they pre-diabetic, all of these things, and it's more so genetic because of their family history. So I find that those folks are they come and they're already a little bit, I don't want to say depressed, but they're kind of like, Kai, this is so hard. I work so hard. And I feel like because of my family history, I'm behind the eight ball on this. How do you give hope to those people to say, you know, don't give up on your health just because you have some of the family history that's there already somewhat predetermined?
Trying to plug in my iPad. Well, first of all, how old was your grandpa, dad, whatever, when he developed his heart disease? And was he or she taking care of themselves? Because you can't make your family history go away, but you can improve your own diet, your own status by managing all of these risk factors. So although I've heard specific questions. My dad died when he was 35. He dropped dead from a heart attack, and that does happen. Then they can improve their lifespan just because they inherited this disease or this tendency to have a disease. Their experience does not have to be the same as their family members, and they can have a huge impact on their own health by taking care of their own health and their risk factors that we just mentioned. They can also delay the onset of their disease process by limiting these risk factors. I see a lot of patients who have a family history, like a really strong family history, and the wisest among us seek help and say, what can I do to limit that? I find I don't own stock in any of this about what I'm about to say, but a cardiac calcium CT score is huge. It's a CAT scan, and it takes like 30 seconds. It takes an hour to get there and register and blah, blah, blah. But the test itself is just a couple of minutes. And it's low radiation, and it's high yield in terms of information. Calcium is deposited in places in our body that are injured. And in the case of blood vessels, that injury is usually caused by oxidized LDL or bad cholesterol that attacks the lining of the artery itself and starts a plaque forming. Calcium is deposited into that plaque, and we can calculate the amount of calcium that is in those arteries. And the amount of calcium and the location helps us determine what your risks are depending on that. And that can be a very, very helpful tool.
Yeah, I actually want to share. I've been dealing with some health issues that gave me some heart symptoms. Went to a cardiologist, and they didn't, all the testing came back fine, which was great to hear. And then I'm working with a different practice on some of the other health issues, and they actually had me go, I don't know if it's the same scan you're talking about, but they had me do a heart scan, and they actually had me scan the carotids here to see if there was that buildup. And thankfully, everything was clear. On the other hand, my husband actually had some calcium buildup. And so that was a little concerning. So, we've been kind of working on his nutrition, and he exercises, probably drinks too much. He's not going to listen to me on that one. But
Yeah.
anyway, I just think one of the questions I was going to ask is, what types of preventative screenings can you do to look for things like that? So, right?
So I highly recommend those screenings. And so most of them are kind of put together in a bundle, and they focus on people who are older, because that's when your risk of developing problems usually starts showing itself. But there's nothing wrong with doing it at an earlier age either. I think to focus on menopause, I think when you start having your premenopausal symptoms, or your menopausal symptoms. I think that's perimenopause. There you go. It encompasses everything. That it's a good time to start thinking about those screenings. And most of the screenings include a carotid duplex, a screening carotid duplex, which is an ultrasound of the carotid arteries that identifies whether or not you have any blockages. Now, they're not a medical test. It won't tell you exactly how much blockage you have. So if you have a screening and it shows you have blockages in your carotid arteries, you should follow that up with a visit to your doctor to pursue a more diagnostic test. Most of those screenings also include blood pressures taken in the upper and lower extremities. That helps identify peripheral artery disease or blockages in the arteries of the legs, which is very prevalent in smokers, as well as diabetics, unfortunately. And then the other screening test that is typically done is an ultrasound of the abdominal aorta to identify abdominal aortic aneurysms. So I highly recommend any of those.
And are those
And you can get them, they're frequently offered in a package.
okay. Is that something you could just go do on your own, or you have to have a doctor
Right.
order?
You do it on your own and you pay cash for it. Most insurance companies don't pay for it. Most insurance companies don't pay for a cardiac calcium CT score either, but those are available in most major medical facilities like, Penrose, or Common Spirit, UC Health. They all have this. You can call any of them and say, I need a cardiac calcium CT score. You pay for it out of pocket. It's about $200. And the screening thing that I just talked about is generally less than $200. I can't specifically address the cost at this point, but it's less than $200.
Yeah, I want to say I don't remember both tests, but I do remember I was surprised when I got the carotid scan done and it was just $75 to do it. I was like, wow, everyone should be doing this for $75.
Yeah.
Wow.
Thank you.
Awesome. So another question, Dr. Harris, is with AFib, you talked about gaining control of your high blood pressure if present outside of taking meds. What should you do to decrease your risk? Can you eventually get off the blood pressure medication?
Okay, so that sounds like the question's more about high blood pressure than atrial fibrillation, right?
Yeah,
I
think that
again,
you want me to ask it again.
no, I can combo of both. It looks like so high blood pressure, and I should mention that your doctor should address these things with you at the first time you're diagnosed with hypertension. So the ways that you can reduce your blood pressure without taking a medication are to limit your sodium intake, which is huge. Sodium's in everything. And so it's important to read labels and look for the sodium content. And the goal for sodium is generally 1,200 to 1,500 milligrams a day or less. It kind of depends on your health status in general, but that can be looked up on the American Heart Association website. But at any rate, limit your sodium, exercise, decrease alcohol can increase your blood pressure. And so the first step is to decrease your alcohol consumption and then maybe even stop it. Exercise can lower your blood pressure. Losing weight can control your blood pressure. All those things that we already talked about can help lower your blood pressure. And so depending on the measurement of blood pressure and how high it is, I always talk about these things for reducing your blood pressure, but if the blood pressure is really high, then it's really important to get that down as soon as possible. And so I'll frequently add a medication, and as the patient incorporates these other mechanisms into their own health and taking care of their own health, I can sometimes reduce the dosage or maybe even stop it, depending upon, how much weight they had to lose and how out of shape they were to start with. So, but I would not delay it I'd start it. I don't want to get into real specifics, but like if you're a person who is 50 pounds overweight and your blood pressure is really high, then you might want to consider starting a medication while you're losing weight, while you're taking care of your health in these other ways, knowing that in the future you could come off of it, but taking care of it at that particular time. Hope that answers your question.
Thank you. And then I have, so my dad has had AFib for years. He's 84 years old. He's had many ablations, many cardioversions. Pretty much, I suspect at that age, you're just going to have to deal with that the rest of your life. But do you see that people with AFib that, is there any statistics that it goes away for some people, or do you find that once you kind of have it, it continues to be there?
So
I know when it comes
we
to Colorado to visit, he seems to go into AFib more often because of the high altitude.
Yeah. And so what we say in cardiology is AFib begets AFib. So once you start having an AFib, you're more likely to keep having it and have more of it. The ablations help, but don't guarantee that it will go away and stay away, because you might remember when I talked about AFib and the atria, that there's electrical tissue all over both atria. And so they can both start any place in there can start the circuit of atrial fibrillation. You didn't ask specifically about blood thinners, but most of my patients, if you have AFib and you need to be on a blood thinner, you're pretty much on it for the rest of your life. Nobody ever wants to hear that. There is a new procedure I say a new procedure, it's been around about 10 years now, called the Watchman, WATCHMAN. So in the left atrium, there's a little finger-like projection called the left atrial appendage. That's where most clots form in atrial fibrillation that then go to the brain to cause a stroke. And let me say that the clots that form from atrial fibrillation don't just go to the brain to cause a stroke. I've seen them go to the kidneys and completely kill a kidney because it blocks off the blood flow. It can go to the arterial supply to your gastrointestinal tract and cause ischemia of the intestinal tract. It can go to a toe, and so it can go anywhere that blood goes in your body. It's just that the carotid arteries are the first arteries that come off the aortic arch. And so that's, the blood clots frequently take that exit to get into your brain. But at any rate, the Watchman is kind of like an upside. So if this is the left atrial appendage, and here's all the left atrium out here, then the Watchman is inserted through the groin and comes up and is more or less like an inverted umbrella that we put over the left atrial appendage so that the opening is occluded. And it stays, so the tubing's all taken out and this little umbrella thing stays in place. Over a period of about 6 months following that, you have to be on blood thinners because your body will recognize this little umbrella as a foreign object. And when your body recognizes a foreign object, it clots. And that's just the way we were made. And so you have to be on a blood thinner to prevent that clotting. But after 6 months, You can stop the blood thinner because your body puts a layer of epithelium or, endothelium, a layer of tissue, so that your body no longer recognizes it as a foreign object. And that's the way some people can get off blood thinners. So.
Very interesting. I didn't realize there's all these different screenings and bundles. I think we need to get the word out more about those so people kind of know what their risks are.
I can't think that it's called life screen, maybe life something or other, but they're available all over the place.
Okay, that's great.
And there's even some that are available in like mobile units that go to different parts of the state that have less access to healthcare.
Right. Okay. Wow. Does anybody else have any questions for Dr. Harris as we wrap this up? You can put them in the chat or you can just ask yourself.
You're welcome, Christine.
We have lots of thank yous that came in for you as people had to get to kids or other things, but we really, really appreciate your time today. It was very, very educational and very well thought out as to what you shared. We appreciate that so much. I know I keep this around my little heart squeeze, ball that I got years ago to remind myself that, to kind of lower the stress. I think that's probably my highest one that I deal with on a daily basis, is trying to be a little bit more calm and try not to overschedule and overcommit, and recognize that ask for help.
Absolutely.
Community, we can ask for help with carpooling and other things instead of feeling like we have to do everything ourselves. So, but without any further ado, we'll thank you for your time today. I'd love if everybody's able to do a little heart. We'll get a little picture with Dr. Harris here to thank her. Let's see how good I am at got our little hearts ready. 1, 2, 3. And we appreciate your time. And Dr. Harris, I'm just going to get one of you by yourself. So take a big smile. She's so cute, isn't she? I love how she always has different color glasses. How many pairs of glasses do you have, and how many
I have
colors?
one pair of glasses and multiple
That's
things
smart.
on top of.
So cool. Wow.
My
I've never
favorite
seen
thing
that.
to do. My favorite thing
I've
is
never
somebody
seen that.
says, "I love your glasses." I say, "Thank you." And anyway, they're fun.
I've seen you wear red and all sorts of colors, and I'm like, oh, that's just the coolest thing. So yeah, but thank you so much for sharing, and we will be putting this recording into the group for people to be able to watch this. And if you have family members that you feel like should watch it with you, invite them to do that as well. The more people we can keep healthy, and recognizing that everybody has to do their part. People like to hire personal trainers and other things to help them, but you have to do the hard work. You have to make those healthy choices, and it's hard, but it is worth it in the long run. And I think the big thing that I've learned through so many things is people that don't feel good on a regular basis don't know what it's like to feel good.
Right.
And when you feel good, it's amazing, right? And Heather, you've been through so much with your health. That year you didn't feel good. It makes you really appreciate feeling good. So if we can really help people to recognize the importance of daily activities, that people will look at some of us in the health field and be like, well, it's easy for you. And it's not. Every day is a challenge, and it's about consistency. And that's what it comes down to, is being consistent. And I think, the good part about women is I feel like women are a little bit better about recognizing that they need to do something, even though they do take care of their kids and everything else. Men, sometimes it's hard to change their mind. Like Heather said, telling my husband he needs to drink less alcohol. They don't want to listen to us, right? But I feel like women listen to other women. And so I think this is our opportunity as a woman. Each person here has that opportunity to talk to your friends and help them as well make healthy choices, because we have the capacity for that ripple effect. So thank you so much, Dr. Harris. Thank you, everybody,
Thank you,
for being
Dr.
on.
Harris.
And I'd like to thank everybody for their attention and their really good questions. I really enjoyed talking to all of you.
It's great. And she was so great about saying, I'd love to help in the community and be able to share her knowledge. And that's just such a gift. So thank you for continuing to, um, people keep wanting to snag you from retirement here. So, so
Okay.
thank you for sharing. And thank you all for caring enough to take the time for you today to learn and to grow and to move forward in a positive manner. So we will see Heather next week to learn about eating for your heart. And Dr. Harris, if you don't mind, when you get a chance later this week to send me your salmon recipe, I'd love to share that with the group. And we'll be talking about that. And then our final week is with Dr. Wendy Day, who's both mine and Dr. Harris's primary care doctor. She's going to be talking a little bit more about menopause and should you have testing for hormones? How do you deal with all of that piece of the puzzle, which can be very confusing and very overwhelming, I believe, and really understanding that piece, as she is a big proponent too of exercise and getting outside and being healthy as well. So thank you guys for being on today, and we will see you next week, and we'll see you every day in our group. So have a great week. Thank you.
Thank you. Bye-bye.